Started. Any of your friends still in the toilet? Do you need to call them, or you think they're all back already? It looks like everybody might be back already, so I'll get started. So far we have discussed where the stomach, the pancreas, and the livers are, and we've discussed cancers of the stomach, cancers of the pancreas. So now we have a very big area called the liver, and for the rest of the talk this morning, I'll be talking on the liver. So just to refresh everybody's memory, this is where the liver is. The liver is in the front, is in the upper part of the abdomen. Parts of the liver is actually underneath the rib cage, and because of that, you can't really feel the liver unless the liver is enlarged to some extent. So this is where it is, and you can see the gallbladder peeping up from just underneath the bottom edge of the liver. If you remove the liver, behind the liver is the stomach, the pancreas, and so on. Now, cancers of the liver, there are either primary liver cancers or secondary liver cancers. So primary liver cancers are cancers where the cells of the cancer actually arises from the liver itself. And the scientific name for this is hepatocellular carcinoma. In Asia, this is by far the most important cancer, and I'll talk to that in some detail later. Of course, cancers in the liver can be cancers that's gone to the liver because the origin is in another place, for example in the stomach or in the intestine, and these are called secondary liver cancers, and their treatment is related to the primary liver cancer. So for my talk today, I'll concentrate on primary liver cancer, a very important cancer in our part of the world. Now, primary liver cancer is unfortunately very common in the Asia-Pacific region. Of course, this is a picture of a place in Myanmar that I visited. This is typical of the Asia-Pacific. So most liver cancers are found in that part of the world. If you look at the data, more than 70% of all liver cancers are found in the Asia-Pacific. And the incidence in North America and Europe is in fact relatively low compared to our incidence. It's also found in parts of Africa, but the population in Africa is very small. Now, why is it that it is so prevalent in the Asia-Pacific, and what are the causes of liver cancer? The two most important causes of liver cancer are actually chronic hepatitis B and chronic hepatitis C. The rest of the causes are in another group, which is less important. So I'm going to talk about chronic hepatitis B and C first, and then I'll talk about the rest. Now, there are many types of viral hepatitis. So the lay public is sometimes confused. How about hepatitis A and so on and so forth? Of all these types of viral hepatitis, the important ones that we have are hepatitis B and hepatitis C, and to a smaller extent hepatitis D, which is related to hepatitis B, because these are the kinds of hepatitis that has a chronic condition. That means they can stay in your body for a long, long time. For example, for hepatitis A, you get it, you recover, and that's it, you don't have a chronic condition. And these are the two that gives rise to liver cancer. Hepatitis B is actually a very important cancer. The worldwide prevalence is actually 6%. Hepatitis C is 2%. So hepatitis B is more prevalent than hepatitis C. And hepatitis B accounts for more than 50% of all liver cancers. But there's a great geographical variation, which also tells you why liver cancer is more common in the Asia-Pacific than in the West. In places like Korea, more than 70% of liver cancers are due to hepatitis B, but in Sweden it's only about 3%. And this relates to the distribution of hepatitis B. Now, if you look at all the patients with hepatitis B, chronic hepatitis B in the world, about 2/3 of them, or 66% of them, are actually from Asia. And because of that, most liver cancers actually arise in Asia. How do we avoid liver cancer? Now, it is a mixture of both public health measures and private measures, and this is where you can do something about that, but it's also very important for a good government to do something about that. And in that sense, we are fortunate here. One of the most important things that you can do to prevent liver cancer is actually to vaccinate yourself against viral hepatitis. Now, there are two types of viral hepatitis. You can have vaccination against hepatitis B because it is what we call a DNA virus. But unfortunately, there is no vaccination against hepatitis C. But in our population, hepatitis B is much more important than hepatitis C. In about 27 and 28 years ago, we became the second country in the world to have universal vaccination. That means all children born are automatically vaccinated. But that also leaves a lot of people, including most of you in this room, who are not vaccinated at the time that you are born. Now, if you are vaccinated, this is what we call primary prevention, because you remove the cause of the cancer. But if you already have viral hepatitis, then you have to go into what we call secondary prevention. You have to treat the viral hepatitis. And today there are many, many good drugs that are available for viral hepatitis to be treated. And if viral hepatitis is appropriately treated, the risk of getting liver cancer actually drops quite significantly. Now, these are all blood-borne viruses, and it is very important to have public health measures in place. For example, a good blood bank that screens the blood of blood donors to make sure that they're not carriers. And of course, very good public health measures in the hospital also to prevent body and blood contamination. And of course, on the individual level, you have to avoid high-risk behavior that gives rise to getting chronic viral hepatitis. How is hepatitis B transmitted, for example? The mode of transmission for hepatitis B and C are similar, so I'll just touch on hepatitis B. An important important route of transmission is sexual, from sexual intercourse. So sex workers are particularly at risk, right? But many patients get it also through the parental route, for example, through the blood. And for example, IV drug users are particularly at risk because they share needles and so on. Healthcare workers, doctors, nurses are at risk because of the way they deal with the patients. The surgeons, for example, the chances of getting it is higher than the average person in the population. And this is because some of our patients also have hepatitis B and C. And of course, contaminated blood transfusion is an important cause in many countries, but in Singapore, our very good blood bank screens all of this. But in many parts of Asia, patients don't get hepatitis B because they are IV drug users or because they are sexually promiscuous. They get it from their parents. Because the prevalence of hepatitis B and to some extent C is very high, mothers can actually pass it down to their children, you know. And because of that, universal vaccination, like what we did in Singapore and Taiwan, is very important. At the time of birth, the child is vaccinated. And if the mother already has hepatitis B, then the child is given medication in order to control that. So these are very important things that has been done, you know. And in most parts of Asia, this is the main way hepatitis B and C are transmitted. Now, if a patient is a chronic hepatitis B carrier, his risk of getting liver cancer is 100 times, more than 100 times the risk of a non-carrier. Now, this is very important. 100 times is not 100%. 100% is 2 times. This is 100 times. So this is a very, very definite risk factor, right? And usually develops about more than 20 years after the patient is infected, which is why they get it at the older age, usually. And it's very important to diagnose liver cancer at the early stage because that's where treatment can be potentially curative. Because if liver cancer is advanced, then the survival is relatively short. So a patient who is already known to be hepatitis B carrier must go for very frequent screening through the blood and through the ultrasound in order to be able to pick it up if the patient would be so unfortunate to get that cancer. What are the other causes of liver cancer? I've talked about hepatitis B and hepatitis C. The others are things like alpha toxins, which is from contaminated grain, rice and so on, does not store properly. Not a big problem in Singapore because we don't grow grains, so our grains are all imported. And NEA does a very stringent check on that, you see. Now the other factors that causes liver cancer are all lifestyle factors. And lifestyle factors are all within our control. That means we can do something about that. We're talking about alcohol abuse, fortunately not very important in Singapore. But very importantly, we are talking about non-alcohol fatty liver disease. We're talking about obesity, we're talking about diabetes, and all these are things that are amenable to lifestyle changes. So things that are within the control of ourselves. Now, what is non-alcoholic fatty liver disease? I think most lay public are not aware of that. This is where there is a lot of fat stored in the liver in the absence of alcohol abuse, in the absence of hepatitis B, and in the absence of hepatitis C. Now, non-alcohol fatty liver disease is very common. Most of them are just simple fatty liver. They're not that dangerous, but sometimes they progress to what we call NASH, or non-alcohol steatohepatitis. This becomes increasingly dangerous and can give rise to fibrosis and to cirrhosis and therefore to cancer. Now, how common is this fatty liver problem? Most of you probably don't realize it. Fatty liver is actually the most common liver condition in the world, much more common than hepatitis B or hepatitis C. Up to 1/3 of the adults in the North American continent are actually patients with fatty liver, up to 30% of East Asia, and almost 10% of patients in rural areas in Asia. And it is on the rise in Singapore, in most parts of Asia as well, because of lifestyle. We no longer live like our ancestors. We don't farm in the field. Most of us live sedentary lifestyles, and we are prone to getting fatty liver. Usually not in teen people, but it can also happen in teen people. And this is particularly prevalent in Asian countries where you get teen Asian people who already have fatty liver. Overall, again, as I've said, life is not always fair, more common in males than in females. But after menopause, the chances of a female getting fatty liver is equal to that of men. What are the risk factors for getting fatty liver, non-alcoholic fatty liver? The main risk factor is actually high blood sugar. And this is caused usually by insulin resistance and caused by something called metabolic syndrome, which most Asians are prone to. About 2/3 of Asians carry the genes that makes them prone to metabolic syndrome. The diet is very important, and a diet high in sugars and in fructose, for example, can predispose to non-alcoholic fatty liver. Type 2 diabetes, of course, and is linked with obesity, and there's obviously a genetic basis for that as well. Very importantly for us, how does NAFLD and NASH lead to liver cancer? Now, when the fatty liver is no longer simple, let's say it's gotten more complex, such that the liver cells become inflamed. And you will know that, the doctor will know that, because on top of the fact that the ultrasound shows a lot of fat in the liver, your liver function test, your blood test already shows abnormalities, which is to say that the fat in the liver is now causing an active inflammation. Then this condition is called NASH. So NASH is very serious because NASH can give rise to fibrosis of the liver and to cirrhosis, and it can give rise to liver cancer. When I started training as a doctor or as a medical student, we seldom see liver cancer from patients who have no hepatitis B or no hepatitis C. Now, the huge incidence, the huge increase in fatty liver has happened over the last 20 years. So now we are beginning to see, as liver cancer specialists, we are beginning to see patients who are not hepatitis B positive or not hepatitis C positive who are coming to us with a diagnosis of liver cancer. And over the next 50 years, it's going to be more and more important. So this is something to pay attention to, especially because it's something that you can do a lot about. It's not like chronic hepatitis B, you're born with it because you got it from your parents. Just have to control that. But in fatty liver, you can actually do things to reverse the fatty liver. What is the way to do that? Is there a good way? Can you pop a pill and reverse that? Unfortunately, there's no good medicine that you can take for you to reverse fatty liver. But fortunately, fatty liver can be reversed by lifestyle. If the fatty liver gets worse, the liver will fail, and you'll be interested to know that in America, liver transplantation is in fact the third most common reason why a patient gets a liver transplant. Of course, liver transplantation is very, very drastic. But there are ways that you can do for yourself, to help yourself, so that you do not reach that stage. And these are all lifestyle measures. Weight loss is very important, especially if your weight is more than ideal. But when we talk about weight loss, we're not talking about losing 1 or 2 kilograms, because that does not really reverse fatty liver. We're talking about a loss of weight of at least 10% of your body weight. So for example, if you're an 80-kilogram man, I use the term man because it's more common in men, then if you want to begin to reverse your fatty liver, you have to lose at least, if you're 80 kilogram, to lose at least 8 kilograms. 70 kilogram, to lose at least 7 kilograms. Then after 6 to 9 months, your liver begin to reverse. So I've got many patients who have successfully reversed their fatty liver because they're concerned enough to change their lifestyle. If you do that, then things improve. And one of the best ways, of course, is dietary control. The other is, of course, to do exercise. A lot of my patients tell me they do exercise, but the kind of exercise they're talking about really is not going to do a lot for fatty liver. So, for example, window shopping is an exercise, but it's not going to help very much. You're talking about relatively high intensity exercise, because if the exercise is high intensity, it gives rise to hormonal changes in the body that helps you to reverse fatty liver. So exercise as a modality is important, but only relatively high intensity exercise. So if you have not exercised for 30 years, don't go suddenly into high intensity, then you have other problems with your heart, is it? So it's probably a combination of diet, watching what you eat, cutting down on the sugars. Sugars are very important. Fatty liver doesn't come from eating fat. It comes from eating refined carbohydrates, especially sugar. So patients come to me, the other thing I do is, of course, gallstone disease. They are detected with gallstone disease. We take out the gallbladder for that. And by the way, they have fatty liver. And the patient say, but doc, Prof. Chow, I don't eat fat at all. But they don't realize that they may have been consuming a lot of glucose, a lot of sugar, carbohydrate, and that is the one that predisposes to fatty liver, right? Does a lipid lowering drug help? For example, anti-cholesterol drugs, they help a little bit, but they are not the main way to reverse fatty liver. The main way to reverse fatty liver is really through lifestyle changes. So now we come to the important point. How do you know you have liver cancer? What are the signs, the symptoms of liver cancer that you should look out for in yourself and your relatives? And how do you diagnose that? Now, what is a typical patient with liver cancer? Well, the typical patient has got either chronic hepatitis B or C, or has NASH. And again, more male than female, unfortunately. For every four male liver cancer patients, we get one female liver cancer patient. Usually a bit older, more than 40 years old, because it takes a while for the chronic hepatitis to actually affect the liver in that manner. Now, the irony is that liver cancer that has got no symptoms are the ones that do the best, because this tends to be the early liver cancers. And early liver cancers are actually picked up only if you go for screening before you get symptoms. By the time you get symptoms, usually it means that it may be not early anymore. The early signs are usually quite vague, some discomfort, some loss of weight, or you know that you already have hepatitis B and you are quite well and suddenly you deteriorate, then you realize that you may have been developing liver cancer. If the tumor is very large, they can irritate the diaphragm and cause you pain in the shoulder tip, but that's quite uncommon. And of course, sometimes the tumor does rupture. And of course, if the liver ruptures, you get sudden abdominal pain, you go into shock, you go to the hospital, you have to be admitted to the A&E department. But fortunately, this is not so common. How do you diagnose liver cancer? And the diagnosis of liver cancer is a bit different from many other cancers. The diagnosis of stomach cancer, breast cancer, colon cancer usually requires a biopsy. But biopsy is not something that we recommend for liver cancer because it can spread the cancer, right? And of course, there's a risk of bleeding as well. Diagnosis of liver cancer is mainly done by advances in radiology, in imaging, and so on. And the diagnosis of liver cancer is based on peculiar features of liver cancer that are seen on the CT scan or the MRI. So if you do a scan for liver cancer, you do something called a multiphasic scan, which means that within a minute's time, the radiologist does a series of scans for you, catching what we call the arterial phase and the venous phase. And because of the particular features of the cancer, liver cancer tends to be supplied by only the artery and not the vein. Then you can see something that lights up on the arterial phase and washes out. This is very, very diagnostic of liver cancer. And liver cancer today is internationally diagnosed by radiology and very rarely by biopsy. So what happens when you have liver cancer? So if you're unfortunate, or if your relative is unfortunate and has liver cancer, what do you do now? What's the best way to treat the liver cancer? Now, liver cancer is a very challenging cancer to treat, more challenging than breast or colorectal, for example. That's because a patient suffering from liver cancer usually suffers from two diseases at the same time. The liver cancer has probably a reason because the liver has hardened already, either because of chronic hepatitis or because of NASH and so on. So the liver function itself is already quite poor, right? So on top of that, you've got cancer. So these two together makes the treatment of liver cancer quite challenging. But after hearing this bad news, the good news is that over the last 10 years, there's been a lot of developments in the field of treatment for liver cancer. And in fact, the clinical outcomes of patients who have liver cancer today is much, much better than those for example, 15 years ago or 20 years ago. And the new treatment that we have much less side effects than those in the past. And there's lots of ongoing research going on in the world, and also in Singapore, and also at the National Cancer Center, that will, in the next 5 or 10 years, give rise to hopefully better treatment and better outcomes for patients. Now, when surgery is possible, then surgery really is the one that gives you the best long-term survival, and today is the standard of care, which means to say that if possible, you should have surgery. And there are many reasons why the results of surgery has improved over the last 2 decades. One of them is because I think the doctors are better at choosing the patients to go for surgery. And increasingly, the surgery are done in academic medical centers, like the Cancer Center, for example, where a group of experts get together to treat the patient, as opposed to, for example, a district hospital. Our anesthetic colleagues have improved their ways of managing the patient during surgery. And more importantly, when the cancer comes back, we have many, many good therapies that we can salvage the patient with. And I think these are the reasons why the outcomes of liver cancer has improved quite significantly over the last 10 to 15 years. So the results of surgery are good. And the main challenge to liver cancer is not that the surgery is poor, but because most patients with liver cancer are not candidates for surgery at the time they are diagnosed. We are talking about 80% of the patients. And this is the group in which advances in treatment is the most important, because these are the majority of the patients. Now, if the tumor is very small, but because the patient is not fit or the liver is no good and surgery is not possible, then one very good way to treat it is what we call radiofrequency ablation. This is done with the help of the interventional radiology colleagues. So the radiologist put in a probe into the middle of the tumor, right? And then when it's in location, he turns on the current, and the tips become very hot. So the liver cancer is killed by cooking, right? Some of you must be hungry, right? Now, because of that, the middle part of the liver cancer that's been cooked is, of course, very well done. But you can imagine that if the liver cancer is big, the rims are only medium rare, isn't it? So which is very good for small tumors, but not very good for big tumors, because if it's medium rare, then the cells have not died and will recur. So for small tumors, radiofrequency ablation is very, very good. The results are almost similar to surgery. And for early liver cancer, transplantation is also useful, but not for late cancers. And this is the landmark study done in Milan that shows that for early liver cancer, transplantation is very good, but for late cancers, they are no good. That's because in late cancers, in liver cancers, there are already a lot of cancer cells circulating, and you transplant the liver, you need to immunosuppress the patient, and of course the liver cancer comes back very aggressively. So what about those patients that cannot be treated by surgery or by transplantation or by radiofrequency ablation? These are by far the majority of the patients. Now, when they are in this category, they can actually have disease that is metastatic, that is to say that the cancer has already gone to the bone and to the lungs and so on. Or they can have disease where the cancer is just confined to the liver. Now, for cancers that have gone to outside of the liver, what we call metastatic disease, today there's a drug that's useful for that. This drug is called sorafenib. It is what we call a molecular targeted therapy, and this is a very recent development. The positive clinical study was only announced in 2007. So for the last couple of years, or from 2007 until now, we have access to this drug to treat patients where the cancer has gone outside of the liver. But a lot of the patients have cancer that are still confined to the liver, but too advanced for surgery, too advanced for transplantation, and too big for RFA. How do we treat this group of patients? A very old way is to treat them using something called transarterial chemo-embolization. In this case, the interventional radiologist put in a catheter through the artery going into the liver and inject some chemotherapy, after which he blocks up the artery. This has been used for a long time. This does prolong survival, but the efficacy is not very high. More recent development is the use of selective internal radiation therapy with radionuclide yttrium-90. This is very useful for larger tumors or for multifocal tumors, as to say that there are multiple tumors in the liver, including those cancers with involvement of the vein. So this is called selective internal radiation therapy. And in this therapy, the interventional radiologist colleague put up a catheter through the artery going to the liver and injects very small spheres called microspheres that carries radiation in the form of yttrium-90. These are very strong radiation. is beta radiation, so the range is very short. So it's injected right there and it destroys the tumor without destroying the non-cancerous part of the liver. And after this is delivered, our nuclear medicine colleagues will do a scan to show where the delivery of the yttrium is. And this has been very useful for us, and it has led to control of cancer in many patients. Some patients have it downstage for resection. So now, for once, in the history of liver cancer, we have a lot of ways that we can treat liver cancer with. But in that case, if there are so many ways to treat liver cancer, what's the best way to treat liver cancer? Is that very confusing? Because the reality is that a wide range of liver cancers present itself. This small liver cancer, small tumor is a liver cancer. This moderate-sized tumor is a liver cancer. This very advanced cancer is also liver cancer. Surely the treatment must be not the same, isn't it? It can't be all the same, right? How do you treat them? How do the doctors choose? So we have a joke in the hospital, and this is a joke that we tell all the time, and you can identify with that. So a patient with liver cancer comes to the hospital. He walks down the corridor, and he meets a very senior nurse. He tells the nurse, "I've got liver cancer. Which doctor should I see? There's so many doctors, I'm confused. There's a surgeon, there's a medical oncologist, there's this and that." Then the nurse, being a very wise person, asks the patient, "What kind of man are you? Are you a radical man? If you are a radical man, you turn to the door to the left. Right? The leftist is inside. He is called the surgeon. He will cut it out for you. Right? Are you a conservative man? If you are a conservative man, enter the door to the right. The internist sits inside. He'll pop a pill for you. Right? But surely the treatment of liver cancer, something that's so important, shouldn't be left to the door that you turn in, isn't it? Isn't there a better scientific way? Right? There is. Because the choice of the best treatment for the patients really depends on the stage of the cancer, depends on the general health of the patient, and of course depends on whether the cutting-edge expertise is available. And there are so many new therapies coming, so sometimes it's not possible for a particular specialist to know all the therapies that's possible. So for a cancer like liver cancer, where some of them are treated by surgeons, some of them by medical oncologists, some of them by interventional radiologists, some of them by nuclear medicine physician, the best way for a patient to receive the most appropriate treatment for his stage of the cancer in relation to his health is really to have the treatment in a multidisciplinary manner. So in a multidisciplinary manner, and this is what we do at the National Cancer Center, all the cases that are presented to us are discussed in a board of different specialists so that everybody can contribute expertise to this patient to see, well, for this patient with this particular stage, I think surgery should be the way to go. For this other patient, maybe we should have yttrium-90 with selective internal radiation. For the other patient, maybe we should have radiofrequency ablation. So we sit together and discuss, so that everybody contributes. So that there's no confusion as to where everything is. This is where we are, We discuss the patients in this way. So this is what we do at the Comprehensive Liver Cancer Clinic at the National Cancer Center. So the needs of a patient also changes from time to time. The patient may present with early disease. Then our board may say, let's go for surgery. So surgery is done. 2 years later, he may have a recurrence. Maybe it's time for the radiologist to do radiofrequency ablation. Then another 2 years, he may have multiple recurrences. Then maybe yttrium-90 is the way to go. And maybe later on, he's got spread to the lung. Then the medical oncologist steps in to give the patient sorafenib. So the patient should be treated in a spectrum like that because his disease also progresses with time. And it's with this that the patient can get the best possible outcomes. Now, is early detection and prevention of primary liver cancer possible? Everybody should be screened for chronic viral hepatitis. If you are immune, good. You don't have to worry about this. Just worry about your lifestyle and don't get fatty liver, right? If you are not immune, go for immunization. The polyclinic does that very well. If you are a carrier already, you should go for regular surveillance, 6 monthly, using a blood test called alpha-fetoprotein and ultrasound. You must do both. Because each one of them can have a false negative, but to have 2 false negatives together, you must be pretty unlucky, right? You can prevent, so immunize yourself. Hepatitis C, you cannot immunize, so avoid high-risk behavior, right? Try not to get blood transfusion in foreign countries where the blood bank may not be so stringent, and avoid other causes of liver cirrhosis, such as alcohol use, unknown drugs, and of course, keep yourself fit so that you have no fatty liver. So in summary, the clinical outcomes of treatment for liver cancer has actually improved quite significantly over the last 10 years. Better outcomes with surgery, with sorafenib, with selective internal radiation, with radiofrequency ablation, and ongoing research, including those that we do in Singapore, will continue to improve outcomes in these patients. So, liver cancer should be managed as multidisciplinary cancers now. We started a comprehensive liver cancer clinic in NCCS about 3 months ago, and there you get all the specialists required: the surgeon, the medical oncologist, the radiation oncologist, the radiologist, the medicine, and so on. Thank you very much for your attention.